Yeah, my name is Dr. Kashan, and we would be doing this examination skills today. Can we start? Okay. So, first of all, welcome you guys in this session, and the purpose of this clinical session is to give you a hands-on practice of how are you going to tune up your skills. I hope that you guys have already exposed to your ENT rotation, your ophthalmology rotation, and you probably have an idea of otoscopes. Did you guys see otoscope in person, or you hold it in person in your ENT rotation? Not get a chance. It was online altogether. All right. Okay. Here in the family medicine, it is required you not to do as from the ENT perspective, but what is required from the family physician, or I can say primary healthcare perspective. We will discuss about how you're going to use otoscopes in primary healthcare when you go into your clinics. And I would advise to get a hands-on practice of how we should do it. And we will start with the presentation. Okay. So for the otoscopic examination, we would try to make it very brief, and what is actually required for you to perform, and what are the things that we probably need to see and expect you as a family physician. So first of all, we will see how to perform otoscopes, and ear pains, otitis media, otitis externa. These are conditions. Only these conditions are required for you to actually have a good skill of diagnosis. You are expected to diagnose it. You are expected to manage these issues. Ear pains and discharge. Okay. How to perform? If anyone can come, I just need one volunteer. All right, please have a seat. All right, once you start off with your otoscopic examination, you first need to introduce yourself. Assalamu alaikum. My name is Dr. Kashan, and today I am going to inspect your ear and do some otoscopy. Would you allow me? All right. Okay. Now, after you take the consent, you ask the patient, "Can you smile for me?" Yes, without a mask. Thank you. All right. So I am asking the patient to smile. Why? Facial nerve. In order to see the facial nerve pathology. All right. After I ask him which ear is better for you, which ear has better hearing, you see, or both are equal. Both are equal. Good. Do you have any pain? No. If the patient says no, that's fine, because we are here to inspect. Usually the patient says that, okay, I have a pain in the right ear or left ear, whatever is the problem, or a discharge on the right side or the left side, whatever is relevant. So after I take the consent, and I will inspect. All right. Okay. So I've taken the consent from the patient and ask him to smile, and I ask him where is the pain or the discharge, in the right side or the left side. If the patient says on the right side, we will start off from the left side. Obviously, if the patient says left side, we will start it from the right side. So we need to inspect the normal side first. All right. So now we will start our examination as in every case. We started with inspection. So in the inspection, we will see. Can you look over there? Over there. Yeah. So we can see the pinna. Is there any discharge? Is there any redness or erythema, or is there any deformity, and is there anything that you can observe as a local sign of infection? Then you assess for the preauricular and also as a postauricular. So you will see here area preauricular, and you will also try to inspect postauricular. All right. You can see scars, you can see lymph nodes, and you can observe anything that is locally which is causing ear pain or anything. Okay. Then the other thing, before you go on to the otoscopes, you will do Mestoid tenderness. The Mestoid tenderness is you will rotate and then with your 2 fingers you will tap here, Mestoid process. When you tap here, you ask the patient, or you can observe that is there any pain. If he says no, then fine. If he says pain, or you observe that there is a pain or a tenderness in the Mestoid process, then that's actually a contraindication to do otoscopes. Alright, so you make sure that you do it before you perform it. There is another contraindication is if the patient has obviously a discharge coming out. You don't want to do otoscopes. Why? Because you cannot, it's not going to benefit you because there is a lot of discharge in the external canal. Number 1. Number 2 is you may probably disseminate that infection inside if you put it inside in any ways. So obviously if the patient has active discharge going on, it's no use of doing the otoscopes. That can be revealed while you are examining the patient or taking the history. Okay, so that's it. And then now you are ready to do otoscope. So first we will do inspection from preauricular, postauricular. Then we will check for Mestoid tenderness. Is there any tenderness? Okay, now there is no tenderness. You can also on palpation, now you will do palpation in the pinna to see if there is any tenderness there or not. Okay, now we proceed to otoscopic examination. You can hold the otoscope right for the right hand. For the right side you will hold it on the right side, for the left side you will hold it on the left side. Okay, use large speculum. Inspect the observe the external auditory canal. If it is wide enough for the adults, as much as possible you should use the large in order to see large speculum, in order to see the large area of the external auditory canal and the tympanic membrane. Number 1, and hold this otoscope like this, or you can hold it like this, like a pen. All right. For the adults, you will do it upwards, backward. All right, upward, outward, and backward. This is for the adults. And for the children's, you will do it downward, please, upward, outward, backward for the male, and for the adult, for the children's, backward and downwards. So this is how you can inspect the external auditory canal and wax and tympanic membrane, because external auditory canal is oblique. So in order to make straight up, you need to hold it upward, outward, backward. All right. Once you do that, it should be clear for your external auditory canal. Now you will instruct, now you will go inside. If you are holding like a pen, so right ear, right hand. You can stabilize it, all right, and then you can go upward, upward, backward, and then you can go inside. I'm not going to put it actually inside because it's going to harm you. So, and I'm not really sure about the sterility. All right. So upward, outward, backward. This position is also acceptable. This position is also acceptable. You will go it like this, all right, or hold it like a pen. You will do it like this. You first need to also on this. There is a light source inside, and you go inside. So when you are going inside, so what you will see is you will see external auditory canal, and make sure that there are no debris there. There is no wax there. And then when you go inside for the external auditory canal, after inspecting the canal, you will see inside that in front is tympanic membrane. When you go inside and you see tympanic membrane, then you can upwards, downwards, sideways, backways, in that way, so that you can see all the areas of the tympanic membrane. The normal tympanic membrane should look like this, and it should have malleus, incus, cone of light, eardrums. All right. So once you inspect, you go inside into the external canal, you inspect for the external auditory canal any abnormalities, then you go further inside to see the tympanic membrane, and after you observe the tympanic membranes normal, you should know the normal. When you please, I would advise all of you to do these this otoscopes on each others so that you know the normals. Once you know the normal, you will automatically find out the abnormalities. All right. So I think you must be familiar of the normal tympanic membranes structures, malleus, incus, the light reflex is very important, eardrum is very important, you don't see any erythema here, and you also don't see any perforation or any discharge here. All right, that's the normal tympanic membrane. This is otitis media, an inflamed tympanic membrane. All right, and this is the perforation. For the thank you, Muhammad. So for the ear examination, we will revise the steps. Then you will see what you are required is to know the tympanic membrane is the normal structures. Number one. Number two is otitis media, and if there is any problem in the inflammation of the tympanic membrane. Number three is perforation. So these are the three conditions that you should be aware of. Okay, how are you going to differentiate between, so there is a clinical question arises. How are you going to differentiate between patient who is come to you for an ear pain and a discharge? So this ear pain and a discharge, is it otitis? First of all, what is otitis? From where you say this is otitis media, and from here where you say this is otitis externa? Otitis media, from which landmark you will say that okay, infection from this, we say that this is in the otitis media territory, and infection before that it is in the otitis externa territory. Tympanic membrane. Tympanic membrane is the thing which middle ear or external ear in that way. External ear is up to the tympanic membrane, beyond that is the middle ear. So before tympanic membrane, the external auditory canal or pinna or anything, you say that it is otitis externa. After it, you will say that this is otitis media. Now, if the patient is presented to you with pain and discharge, and you don't know this discharge is over there in front of you, all right, and the patient says that this is pain. My question is, if this discharge is from the otitis externa territory or is it from the otitis media territory? Like, was it otitis media which then perforates and discharge all the serous material outside? It will present it like this: pain and discharge. Or if there is otitis externa, we see that there is ear pain and discharge. So we see at the end result, we see okay, there is pain and discharge in both, whether is it otitis externa or otitis media. So how are you going to clinically differentiate between otitis externa or otitis media? Tenderness in the pinna can be more visible in otitis externa, right? But many times you may see this tenderness in the media also if the inflammation is too much, because whenever you palpate here, the internal ear is also going to have mobility and inflammation. So that tenderness cannot give you a clear cut answer that okay, if there is no tenderness, probably it is otitis media. Yeah. You put pressure on the tragus, and then if it is tender, it is otitis externa. That could be one thing. Yes.
Otitis media may have problems with dizziness or hearing problems.
Dizziness and hearing problems, otitis media. Dizziness and hearing problems can also be with otitis externa, because technically speaking the tympanic membrane is not, this is why you're saying is because the tympanic membrane is intact, so probably there is less problem with the hearing. But the problem here, the challenge here in the otitis externa is even there is external physical mechanical obstruction, so that can also mimic as hearing problems because of the mechanical obstruction. You were saying something? Nasal discharge? Nasal inflammation? Not necessarily if it disseminates, and obviously ear, nose and throat, they all are coordinated. Okay. Anything, so you need to see the onset. I think whatever your points are suggesting, tenderness in the pinna, tenderness on giving the pressure on the tragus, this will also suggest that it may have probably a more predominant tenderness here inside rather than less predominant tenderness in the otitis media, maybe or may not be. That depends on the severity of the infection. If the infection is so severe in the otitis media as well, it will also mimic like that. And if there is no, probably usually what happens is the other challenge is whenever there is otitis media and it comes out in the otitis externa territory, it will concomitant with the external territories also. So now you have a mixed picture, otitis externa with otitis media with otitis externa, or otitis externa isolated. You will ask in the history, okay, the patient will give you, doctor, I started off with pain and discharge. So you will ask whether this pain and discharge is they both started at the same time, or someone started first and then later on. So I will give you two things and then you will go into the conclusion. In one condition the patient says that, doctor, I have started this pain, tenderness and discharge at the same time. What 2 days before I started pain followed by discharge the same time. Second patient says that, doctor, I have started pain first 2-3 days back, it was increasing in nature, then after 2 days I observed that there is discharge also going on and that pain subsides. So pain followed by discharge, second scenario. First scenario, pain and discharge at the same time. Pain, discharge at the same time, what is it? Externa. Pain followed by discharge and then pain subsides, externa or media? Media, otitis media. Why? Because there is inflammation in the middle ear, after it perforates the tympanic membrane, that pressure builds up, and actually this pain due to pressure decreases, and this is how you can differentiate on the basis of history that whether is it an otitis media or otitis externa to begin with. And obviously theoretically speaking, in otitis media the tympanic membrane is involved or perforated, in otitis externa it is not, but this is a kind of a theoretical definition. But if when you are in the clinical encounter, you need to differentiate on the basis of the history taking. So this is all written here, differentiated between otitis media and otitis externa. Contraindication is Mestoid process tenderness for the otoscopes. Risk stratification in children's. Children often have, children means infants or bottle fed children's, they often have recurrent otitis media going on. So in addition to treating this child with this antibiotic and antipyretics, you also need to see the risk factors. What are the risk factors in the children who have this recurrent otitis media? So you need to explore in the history, bottle fed or breastfed, make it in the upright position to prevent. So whenever a child comes to you, and probably the mother was saying that, doctor, an infant comes to you actually, and the mother was saying that I have this, I observed that my child is having this difficulty in the pain, difficulty in the ear, and I had to do this in order to make him comfortable. So probably there is something going on in the middle ear, in the ear actually. So you ask the patient if the child is bottle fed or the breastfed. You will actually the bottle fed is or the breastfed. What they will do is whenever the child suckles, it will open a bit of Eustachian tube, and there is less peristalsis. So if the child is lying down, so and the child is bottle feeding or breastfeeding, after it the mother went off to sleep or the child also sleeps, and there is no upright position. So what happens is a bit of fluid, whether it is a liquid or a milk, it goes inside the external auditory canal from the mouth, and it will remain over there. It does not go away, and if it is if the child is fall asleep and the mother does not put him in the upright position, this milk will remain in the external auditory canal and it will not trickle. So it will remain over there and will cause problems or discomfort or later on infection. So you ask the mother that please after you feed, after you bottle feed or breastfeed, ask the children to put it in an upright position so that this amount of milk will go inside or it will trickle down. All right. So this is how you can going to assess the risk factor for recurrent otitis media, the children who has recurrent in the history taking. Number 1. Number 2 is parental smoking. If the child is a bit older, parental smoking can also cause recurrent otitis media. So you also need to explore in the history whether one of the parent is a smoker or not, because this will also give recurrent otitis media. If the children is old enough, 5 years, 6 years, 8 years, and is having recurrent otitis media, you also need to ask in the history swimming. So you observe here, by taking a good history, you actually able to find out the cause of the recurrent otitis media, and then you can actually manage that recurrence, because whenever the child or comes to you in the clinic and having these problems, you will give antibiotic, and then if you don't address these issues, it was going to come back again and again, and it will ultimately result in resistance of the antibiotics. So when to refer? You are a family physician, you are treating a patient with child or treating a child or a patient with ear conditions. When to refer? You will refer the patient if there is unilateral unexplained pain in the head or neck for more than 4 weeks. So if there is a pain going on and you still don't know the cause, you probably need to take an opinion from the ENT what is going on with this patient. It's good that you should take the opinion from the ENT person. Number 1. Number 2 is and you observe that there is tympanic membrane is okay. So if the patient has otitis media or otitis externa on the clinical diagnosis, you find it discharge, you find inflamed tympanic membrane, you give some antibiotics, the patient is resolving but not very resolving, that is not an indication. The indication is that on the otoscopic examination, you don't find any cause of this pain on a local examination, but the pain is not resolving for the last 4 weeks. So that might be an indication to refer the patient out, because it requires some kind of CT to see some other pathology which is causing, or any cancer which is causing inside, which will cause these otalgias. And obviously mestoiditis. You start off with the inspection, you see that there is tenderness in the mestoid process, you immediately need to get an opinion from the ENT. You can start the antibiotic and you make a referral to the ENT, because this is going to destroy the ear. So before it does that, you need to have an ENT on board. So these are the indications for the referrals. All right. So that's about otoscope. So we first start off with the otoscopic examination. You take the consent to the patient, you ask him to smile, then you ask which ear is involved. Start off with the next ear. You start off with inspection of the pinna, preauricular, postauricular, then palpation, tragus, pinna, palpate it, mestoid tenderness, palpate it. Okay, now you are clear with the otoscopic examination. You should hold the otoscopes like that or like this. All right. You go inside, upward, outward, backward. You insert inside from right ear, right hand, left ear, left hand. You go inside, you observe external auditory canal. You go inside further, you see the tympanic membrane. You comment on tympanic membrane, whether is it intact, not intact, perforated, and then you make your diagnosis. You go, you come, you take the otoscope slowly and gradually outwards, and that will complete your examination. All right. Any questions so far? So this is about otoscopic examination. Yes.
Doctor, if we ask the patient to smile and there is pathology, patient has pathology, what will be the...
If there is a pathology, then your diagnosis is okay. Yani you can say that okay, there is facial nerve problem. You can refer the patient to the ENT. ENT, if it is relevant, or neurology. So that depends between what is the cause of that facial nerve palsy.
It's not related to it's not a contraindication to doing the otoscopy.
Autoscope is not a contraindication. However, you don't find the cause of that thing in the otoscope. It's out of the scope of the otoscope. This is the thing, but it's not a contraindication per se. Okay. Any other question? Yes.
Yeah. Another question, doctor, is that what if you said that could harm the patient if you do the otoscopy? What are the complications of otoscopy?
Complications of the otoscopes. If you are doing it not in a correct position, you may probably ended up doing a perforation, because you are actually inserting a manual thing, which is hard enough to actually get a so local perforation is one thing. Number two is, even though if you don't, your analysis is not good, you probably would disseminate that infection from external to the medial ear by yourself, so iatrogenic. So the ineffective technique can do local trauma. Number second is, you may disseminate the external ear infection into inside. So these are the two main complications of otitis otoscopic examination, but it's obviously because of the lack of clinical judgment and lack of the clinical skills that we have. Okay, so we are done with the otoscopic examination.